Good afternoon, everyone. We will begin today's webinar. I'm gonna await Dr. Malin Reyes Rodriguez, who's now turning on her video and audio, and I will go ahead and welcome you. Thank you so much for coming today. A few things to note: participants will be muted upon entry and videos turned off. For technical assistance, please use the chat box. Third, you will receive an email in approximately 3 months requesting feedback/impact on this presentation. And lastly, we'd like for you to visit our website at www.ncdas.org/training to view other training opportunities that we may have. Today's webinar will be presented by Dr. Malin Reyes Rodriguez, who is an associate clinical professor in the Center of Excellence for Eating Disorders, Psychiatry Department at UNC Chapel Hill, and fellow of the Academy for Eating Disorders. She is bilingual, both English and Spanish, and a licensed psychologist in North Carolina, offering outpatient treatment for eating disorders, depression, anxiety, and other emotional life distress issues. In addition to individual treatment, she also provides family therapy, couple-based therapy, and behavioral activation therapy for postpartum depression. Dr. Reyes Rodriguez works with a wide range of ages, which encompass adolescents, young adults, and adults. Her primary expertise is providing culturally sensitive interventions for Latino populations, but also has experience working with patients from diverse cultural, race/ethnicity, and sexual orientation backgrounds. The focus of her research is on the development of culturally appropriate interventions for Latinas with eating disorders, with a specific emphasis on developmentally and culturally appropriate incorporation of family members into treatment. Her current work builds on her experience working with adults with bulimia nervosa in Puerto Rico, which underscored the importance of incorporating the family early in treatment as a necessary cultural adaptation for Latinas. She also works on a newspaper where she collaborates with La Noticia, a Spanish language newspaper in North Carolina with almost 500 points of distribution. I will now welcome Dr. Malin Reyes Rodriguez. I turn it over to you.
Thank you for the introduction, and thanks, NCID, for organizing this webinar. And thank you all for joining me in this specific topic about how we can provide cultural sensitive treatment for Latinx with eating disorders. And I am trying to have more control about the slides. Okay, here we are. So in this webinar, I wanted to first talk about what we know in terms of the prevalence of eating disorders in the Latino population. What are the cultural values and other relevant factors that we need to take in consideration when we are working with the Latino population? And also, what are the cultural adaptations that has been suggested for this population, and how we can integrate the cultural values into evidence-based treatment. And I wanted to illustrate that by presenting a case report. So what we have in terms of the prevalence. So we have 3 national prevalence studies documenting the prevalence of eating disorders in Latinx. The first one, published by Alegría in 2007, she was using the National Latino and Asian American Study data. And I think that what is important from this study is that the survey was conducted in Spanish and English, which I think that capture pretty well the representation of Latinx in the United States with diverse acculturation process. And if we compare the estimate prevalence that they found for Latinx with another national study that was published in the same year, 2007, by Hudson, we see that the lifetime prevalence for BN is a little bit higher in the Latinx sample, equal for males and females, a little bit higher compared to the Hudson study. Years later, we have the study published by Marquez in 2011. They also use the NLAS sample, but they added two additional national samples, the National Survey of American Life and the National Comorbidity Survey Replication Dataset. And they found a pretty similar prevalence than the study of Alegría, a little bit higher for lifetime bulimia, equally for male and female. So higher, a little bit higher in males and female. And then we have the study conducted by Udo and Grillo more recently in 2018, where in general, they found a much lower prevalence for eating disorder across race, ethnic group, surprisingly. So this is why we are seeing a much lower prevalence in the Latinx population, and they use the DSM-5. So, but I think that what is important from this study of Udo and Grillo is that for lifetime BN, they didn't find significant differences across race, ethnic group. I think that the message in these slides is that eating disorders are prevalent in the Latino population. And something that we are seeing specifically in Latinx is higher level of prevalence for males when we compare males from other race ethnic group. That is something that I also found in the prevalence study that I conducted at the University of Puerto Rico system across the island, where we found more prevalence of binging and purging behavior in males compared to females. We don't know exactly why that is happening, but I think that would be interesting to continue exploring why we are seeing more eating disorder symptoms in Latino males compared to males from other race ethnic groups. Additionally to the prevalence, Marquez also explored the lifetime service utilization across diverse population. And what I wanted to highlight in these specific slides is if we look into the lifetime for BN and the lifetime for binge eating disorder, and we see the yellow box is the service utilization of Latinx. And service utilization, we are talking about mental health. We are not talking specifically for eating disorder, but we are seeing that if we compare the service utilization, 42 percentage versus the service utilization in white, which is the blue box, and for African American, the green box, we are seeing a huge gap in terms of service utilization. And that is the same for lifetime binge eating disorder. So why we are seeing this low level of service utilization in Latinx, I think that is important to, in order to understand that, to see what are the patterns that we are seeing in Latinx in terms of mental health. For example, what we know that it is hard to engage them into treatment, and also it is hard to retain them into treatment. We are seeing a lot of early dropouts in Latinx in terms of mental health services. There is a huge stigma about having a mental health disorder. There is a popular saying for Latinos saying, I am not crazy, no estoy loca, no estoy loco. And there is a negative connotation about having a mental health disorders. We are also seeing some specific mental health seeking help pattern. For example, they are waiting until the symptoms are very severe. And there is an underutilized mental health services. And this is why we are seeing this gap in service utilization for mental health in the graphic that I presented before. When I explore barriers, specifically with Latina with a history of eating disorder, I found two different kind of barriers. One related with the system and the other related with more personal barriers. So in terms of the system barriers, we are identifying the clinician bias. And we know that historically eating disorder has been associated with Europeans and white Europeans. And because of that, usually when people see an eating disorder in a different person from a different ethnic or race background, they can associate that with that person. For example, I have a Latina saying that in different occasions, she was talking with providers saying, I think that I have bulimia. And they did nothing to further explore or to ask more question about or make a refer for additional evaluation. The lack of bilingual services. One of the patients waited for about 7 months into finally finding a bilingual services for eating disorder, and the lack of health insurance. And we know that the treatment for eating disorder are very, very expensive, especially if the patient needs higher level of care and they don't have health insurance. That would be a huge barrier to get access for a higher level of care. And then in terms of the personal barriers, we have the motivation, which is something that I think that we are seeing in many other eating disorder patients from a different ethnic race background. The stigma. The same way that in Latinx, there is a stigma about having a mental health disorder. When I explore the stigma about having an eating disorder, is greater than the mental health. They prefer to say, I have depression, I have anxiety, rather than saying I have an eating disorder. In part, I think because has been associated with white, and they don't want to feel that they are struggling with a disorder that is for white. Family privacy, that is very a cultural issue. Everything should be kept into the family unit. There is a sense of loyalty to the family in that sense. Fear of not being understood. And I think that that also could be associated with the stigma. One of the patients mentioned about, I think that I am the only Latina here in the US struggling with eating disorder. I haven't seen any other Latina talking about eating disorder. So I think that the combination of the not being understood, but also the stigma of having the eating disorder, not ready to change, and the lack of knowledge of resources. And I will add, in addition to that, the knowledge of resources and the information in Spanish that they can have access to that. The same way that we explore the barriers, I was interested to explore the treatment facilitator. What can help them to seek help? And we found 3 specific aspects that can push them to seek professional help. One is the eating disorder severity. The same way that they wait until the symptoms are very severe, that is the same that is going on with eating disorder. It's not until the symptoms of the eating disorder are very severe that they feel that they need to seek help. High emotional distress. And I think that the first one, the severity and the high emotional distress, could be related with functioning. If I feel that I can continue doing what I need to do, continue going to work, doing the things that I need to do at home, it's fine. But at the moment that the eating disorder interfere with their daily basis functioning, then that is the moment that they realize I need to seek professional help. And having the support from a friend or a family, having someone encouraging them to seek help, go with them to the appointment. That also was a treatment facilitator. So now moving into the treatment. So what we know in terms of evidence treatment and Latinx, we know that usually the evidence-based treatment has been developed and tested primarily with and for white Europeans. But because of that, we can say that only work for that population. But also we can assume that that evidence-based treatment is appropriate for diverse population, and in this case for Latinx. So when we have to do a cultural adaptation. So we have Gonzalez Castro, who established 4 specific conditions that we can look at in order to know when I need to do this cultural adaptation. And one of them is the ineffective patient engagement, which is something that we are seeing in the Latino population. We talk about the how hard it is to engage them into mental health treatment. Then we have unique risk or resilient factors. And in terms of that, we are seeing the stigma of having a eating disorder, we are seeing the underutilization of mental health services, and we are seeing waiting until the symptoms are very severe. So I think that here we have two specific situations where can justify why we need to do a cultural adaptation. The other element that he presents is unique symptoms of a common disorder, which is something that I haven't seen specific in Latinx, and the poor intervention effectiveness, which, to be honest, in terms of large clinical trials, we don't have a good representation of Latinx. In the small proof of principle that I conducted, what I am seeing is that the intervention can work and can be effective if we do some cultural adaptation to target specifically the first 2 points that we mentioned, the engagement, the retention, and also dealing with the stigma and the low level of utilization of mental health services. So what is a cultural adaptation? It's a systematic modification of an intervention to integrate clients' relevant cultural factor, for example, language and values. And seems like those who are less acculturated can benefit the most from a cultural adaptive treatment. So what are the values that we are talking about in terms of integrating into evidence-based treatment? So these two cultural values, familism and personalism, are the two cultural values that we are seeing that more relevant when we are working in terms of treatment. Familism is the strong value that we have for the family. It's the strong tie that usually is extended not only to the immediate family, but also to the extended family. Family is important, is the lawyer to the family. And personalism is the value that we put into the relationship. And in that sense, we can enhance the therapeutic alliance when we put the emphasis into the value of the personalism. For example, when we call the patient the day before to remind the appointment, when we are asking for some specific barriers, that is the way in which we can show that we care about them, and that could be an enhancement for the engagement, but also for the retention, if we can develop a strong therapeutic alliance. And then we have other cultural aspects, like acculturation. We have Latinx with different level of acculturation. And the acculturation is this adaptation process to the new culture. And what we are seeing in terms of the acculturation and the acculturative stress is the stress related with the acculturation process, is that it's not necessarily about where I am in terms of the acculturation process. It's more about the stress causing by the acculturation process that could be a moderator between body dissatisfaction and eating disorder. So in that sense, if I have the acculturative stress, that could be could play a role into the body satisfaction and eventually developing an eating disorder. Migratory status, we have undocumented Latinx, and they are very afraid about the system. So in that sense, we need to provide like a safe place that they feel comfortable because they are very suspicious about the system. Language barrier, we know, for example, that it is important to provide sometimes the treatment in Spanish. When we have a minor, maybe the minor is bilingual, but then we have parents with a different level of acculturation who only speak Spanish. I think that it's important that we don't use the minor as an interpreter, because that can affect the power in the family system. We can use interpreter if we are in a hospital setting, but also reminder that interpreter can also add their perspective about a situation, sometimes providing additional advice. that not necessarily is consistent with what the provider are saying, can develop like a specific relationship with with the patient. So I think that in that sense, it's a challenge when we have to navigate with language barrier in treatment. Other cultural aspect that we had to take in consideration is food insecurity. That is something that I started noticing in patients who have the experience crossing the border. Usually that process could take 2-3 months where they didn't know about when is the next meal. And some of them having this starvation process and eventually developing binge eating disorder or some kind of binge eating behavior. So I think that now in the eating disorder field, we are exploring more the food insecurity, not necessarily related with the border crossing issue, but I think that if we have a Latinx in our clinic, it would be good to also explore the food insecurity and how that can be play a role in terms of the eating disorder behavior. And nuances across Latinx subgroup is another important aspect. We share many cultural values as a Latinx, but also we are different in many ways when we are from different country of origin. So it's not the same a Latinx coming from Mexico, coming from Cuba, from Central America, from Puerto Rico. And I think that it's important to recognize that. And either the Spanish is not the same across different Latino countries. So what we have in terms of evidence-based treatment, specifically in Latinas, we don't have information specifically about Latino males. So we, in the United States, we have only 2 specific studies documenting some kind of cultural adaptation process. The first one, conducted by Kachalin in 2014, they adapted the CBT self-guidance. And what they found is that the treatment is feasible, and also that it is important to address some family issues. The other treatment that has been adapted is the CBT for BN and binge eating disorder. That is the study that I have been conducted for the last few years. And also I found that it's feasible, but also it is important to add familiarization specifically to enhance the engagement and the retention into treatment. And that was my experience when I did the cultural adaptation of the CBT for BN in Puerto Rico. The process at the beginning was to just test the CBT, and I was spending about 6 sessions having to deal with some family issues, having a family member into session, even when the sample was adult. So what I am proposing in terms of the intervention model for Latinas, based on the experience that I have been doing here in North Carolina, is first that we need to address 4 different layers. The first one is the patient. We need to provide more psychoeducation in order to tackle the stigma of having an eating disorder. We need to provide a more understanding about the consequences of the severity of the condition, because that is one of the elements that can help them to seek professional help sooner than later. How and where to seek help, and working with other emotional factors, for example, the readiness to change, trusting the healthcare system, and also in providers. Then we have another layer is the family. Provide a psychoeducation. What is an eating disorder? I have found that many adults, Latino adults, they don't know, especially when we are working with minors, they say, I haven't heard about eating disorder. I don't know what is that. So providing more psychoeducation, how to support a family member emotionally, but also practical. how and where to seek help. My experience is that they wanted to support the family member, they don't know how. In terms of the provider, we need to create the awareness that this is something happening um, in Latinas, in Latino mills, and it is important to do the assessment. Provide more experience about assessment and what are the treatment available for eating disorder in Latinas or Latinos male. In this case, that was my experience when I started working with a nonprofit mental health clinic in the area of Central North Carolina. That when I asked them about, have you seen Latinas with eating disorder? They say no. And I was very surprised about that. But then when I was providing them more education about this is how we assess eating disorder, these are the aspects that are very important, how to assess. They were identifying more Latinas with eating disorder and not new patients, the current patient that they already had in the clinic for years for treatment for depression and anxiety. And then they realized that they were presenting eating disorder symptoms. So I think that giving them that kind of education and more skills how to assess eating disorder in this population. And bilingual services, we need more providers bilingual to provide services to this population. In terms of the system, that is something that not only for eating disorder, we have seen that for depression, anxiety, we need to provide practical support, transportation, childcare, provide flexible business hour for treatment. Latinx usually work double shift. It is hard sometimes to go for treatment when it is in regular business hour. Providing sliding scales for patients with no health insurance. And I think that this one is for me one of the key elements. Preventing program for eating disorder in primary care setting. Latinx usually use primary care setting. It's a safe place for them. And I think that would be a good place to start educating, prevention, identifying, and eventually could be a good place to provide the treatment. So in general, what we can do when we have evidence-based treatment that has been developed primarily for other population, in what we can do. I think that the best approach is first do a search and see if there are any cultural adaptation. It could be a clinical trial, small trial, could be a case report that can help you to inform about what are the potential modification on treatment. But also, if you don't find something that has been published, you can use the current evidence-based treatment, but I am suggesting with an open mind and flexibility to incorporate modification that you can incorporate based on the literature review, based on the treatment progress, and feedback from patients and relatives. And I think that is important, is listening to the patient and relative, and that also can be very helpful. So now I wanted to move into a case report that I hope that can illustrate you how you can incorporate the cultural values into an evidence-based treatment. So this case was my first Latina that I treated here in North Carolina. And she was a 31-year-old undocumented monolingual Latina. She was on treatment for postpartum depression. And when she disclosed about her eating disorder, the therapist decided to stop the treatment, in part because she didn't feel confident, competent to treat eating disorder. But by making that decision of stopping the treatment, that added another layer to the stigma. The patient was saying, why I talk about my eating disorder, because now I don't have any kind of treatment. So I think that that was very, very sad. And that is the patient who they were searching for treatment for her for about 7 months. until they finally found that I was working with Latinas with eating disorder. And even at that moment was not the timing for me to recruit patients in the clinical trial, but we decided to use her case as a study case to test our clinical trial protocol in order to provide her with treatment. She was living with a partner and two children under the age of 5. In terms of the symptom background, she was presenting with bulimia nervosa purging type, 1 to 3 binge and purge episode per day, BMI 29. And the age of onset was 18. She was on treatment 1 year in her country of origin. She was very depressed and also presenting anxiety and multiple history of trauma. So when we look into her presentation, she was struggling with bulimia nervosa. We know that the first line of treatment for bulimia is CBT for BN. So that was the approach that we used. In terms of language, she was monolingual, so providing the treatment in Spanish was the key. However, it is important, as I said at the beginning, that we need to acknowledge the nuances of Latino subgroup. So she was from a different country of origin than me. I am from Puerto Rico. So in that sense, for me, was trying to be very mindful in terms of my Spanish. Usually I speak Spanish very fast. So I was like slowing down, trying to double check some specific words that I know that are different. Especially names of fruit and food, trying to double check that we were in the same page. In terms of the cultural values, familism was one of the values that we wanted to integrate on the treatment. So having a family member as part of the treatment was one of the goals. And personalism, that was something that was integrated in the way that I was calling her, reminding the appointment. Usually we trying to use a community-based setting, but sometimes for some diverse reason, we had to provide the treatment at the hospital facility. So finding her at the lobby, helping her to navigate through the hospital. When we were making refer, calling providers and having that kind of personal treatment make a difference. At some point she was saying, you make me feel important, that you care about me. And I think that because of the emphasis on the relationship was important for engage her, but also to retain her into treatment. In terms of immigration, the level of acculturation was important to assess where she was in terms of the level of acculturation, and if she was experiencing any acculturative stress. Trust issue, because she was undocumented, was important to double check that she was feeling fine and providing a safe place for her to get the treatment. And some of the issue, because of the postpartum depression, the social services was involved in her case. So it was important for me to be very sensitive about her situation. So for those of you who are familiar with the CBT, we have 3 phases of the CBT for bulimia. So during the first phase, the modification that we incorporated was first a clinical conceptualization. Her story was very complex in many ways, that at some point I felt overwhelmed with her story, and I felt the need to do a clinical conceptualization, very concrete. And I will show you in a bit about the diagram that I draft for her. In part was because of the complexity of her case, but also because of her low level of education. Inclusion of the partner as part of the treatment, that was a key element for the engagement and retention. Close to the timing of the treatment process, she was in a car accident. She was not able to drive. So and she was living in another city from our setting. So in that sense, we needed to have someone who can drive her to the treatment station. Her husband didn't know about the eating disorder, so that was a process to invite him to an appointment and supporting her to disclose her eating disorder with him. Surprisingly for her, he was very supportive, and he said, yes, I can drive her every week, whatever she needs in order to feel better. I wanted her to feel better, not only because for me, but also for the kids. So I think that that was key in terms of the engagement and retention. So we added couple-based session to the treatment. We added community service for medication management. She was very depressed, so trying to identify services at the community in Spanish, but also that was accessible for her in terms of because she didn't have health insurance. An additional issue to address in this treatment was the parenting skills and the trauma history. So here is the clinical conceptualization diagram that I drafted for her. And you can see that was a very complicated story. She was overweight as a child. She was maltreated by her family. She had many bullying experiences that contributing to low self-esteem, over concern about her weight, body image. She ran away from her home at the age of 15 with the desire to be happy. She started living with friends, having a fun life, having sexual abuse at 10 that made her feel hopeless, loneliness, engaged in a relationship with a boyfriend that eventually raped her, was very emotionally abused, um, that contributing to low self-esteem, trauma, having an abortion. She felt sexually used, out of control, unhappy. That was part of the trigger for the bulimia as a way to have more control of her life and to attach the happiness to something very concrete. If I can lose weight, if I can manage my body shape, that will help me to feel happy. So she, at some point, decided to emigrate to US looking for a better life. At that moment, she engaged in the relationship with the partner that was part of the treatment. She was not in love with him, but make her feel safe. So at some point, she was feeling that she was exchanging protection for sex. So basically, she was in a victim role, having no control, sorry uh, for herself, no action. And part of the process was trying to move her to a survival, compassion about her story, taking control over her life. And I think that's something that was key in this diagram was to highlight her strengths, that she escaped from abusive situation, her resilience, and always looking for a better life and happiness. And I think that for me as a Latina coming from Puerto Rico, where we don't have any issue with immigration, was my wake up to understand her story, to understand why sometimes Latinas cross the border undocumented, risking their life. And I think that presenting and trying to make sense about her story helped me to understand her, but also help her to understand her her situation. I was very scared to share to her this diagram. It was very like complicated, and when I share with her the diagram, she looked at me. She was quiet during all of my explanation, and at the end, she looked at me and said, this is the first time that I am seeing all of the pieces of my life together. And now makes sense. And I think that that was the moment that for her makes sense, all of the pieces of her life, and trying to make sense about what I need to do next in order to move from the victim role to be more a survivor. By the phase two, we continue regulating the eating patterns. Um, we were seeing a reduction of her binging and purge behavior. Remember at the beginning, she was 2-3 binge purge per day. Now at that stage, she was purging and binging 2-3 per week, which was an improvement. But in phase two, usually we expect a different kind of progress. We expect that we are about to end treatment and she should be in a different place, right? So in that sense, what we are seeing in Latinx is a late response. So usually in other race or any group, we can see maybe that in phase one, we are seeing more progress. With Latinx, what I am seeing is that the response is more at the end of the phase two. Why that is happening? I think that one of the factors could be because this is a research study that we realize we are ending, and I was trying to communicate that message to her. We are ending, and we need to continue working hard because um, that would be the end of the treatment. And for her, I think that was the last chance to receive the treatment in Spanish and at no cost. So I think that it was not until the end that she realized I need to do something different in order to change my eating behavior. And eventually at the end, by phase three, she was not purging and binging, but I was scary because her late response. But also I think that other factor could be because when we are working with Latinx, there is an additional layers in their life that other clients from other race, ethnic group, they maybe don't have to deal with, or maybe with African American as a minority, they can also struggle with that kind of layer. So I am talking about the immigration process, having family living far away, not having the domain of the language. So there is many other layers that we are seeing in Latinx that maybe can explain why they have this late response. During the phase two, we also continue working with couple-based sessions. Basically, the couple-based sessions were more toward providing him more skills about how to support her with the eating disorder behavior, what to do, how to support her when she was having the binging or purging episode, um, and also parenting skills, which was one another source of distress for them, working, helping them with the parenting skills. And we provided 3 nutritional counseling with a dietitian bilingual, Latina, which was worked perfectly well because she knew about the food that we usually eat and help her to do it eating pattern that can work for the entire family. And by the phase three, we work in relapse prevention as we do with other clients. But in her case, I developed like a concrete plan with potential scenario. Basically was like a relapse toolkit. If you have this situation, this is what you can do. If you have that situation, this is what you can do. So in order to help her to navigate through the treatment termination. So the inclusion of the family in treatment addressed the stigma and shame by sharing their eating disorder with family member. I think that boosts treatment engagement and retention, facilitate the positive changes related to eating pattern because all of the family were together making the changes in terms of the eating pattern. We identify specific triggers of their eating disorder behavior in the family context. So in that sense, it's identifying what the family sometimes making some specific comments that they think that is with the good intention or to help the patient, but could be a trigger. So identifying those specific trigger help the patient to and the family to change that dynamic. Um, Finally, I wanted to share that the same way that we talk about how we can provide a cultural sensitive treatment, we also need to provide cultural sensitive information for Latinx for prevention. So we develop fotonovelas in order to raise the awareness of eating disorder in this population. And in order to be cultural sensitive, we develop a script for females and male adolescent, adults, in order to present like a story. This is like, in English, we call like soap opera. So it's like a script where we tell a story about this character and struggling with eating disorder and what we need to do to help that character. And in the focus group that we conducted, the Latinx, they said that they feel that appeal to them and with the desire to read and they sometimes identify with the character. So I think that also we need to trying to provide more psychoeducation that could be cultural sensitive. So in terms of the final remark, eating disorder, as I said before, are prevalent in Latinx. Primary care setting could play an important role on early detection and treatment delivery. There is very limited evidence-based treatment for eating disorder in Latinx, so we need to do better. We need to add more Latinx into clinical trial, especially large clinical trial. We need to well inform about the cultural values, especially if we are not from that cultural background, and also recognize our own biases. As I said, so me as a Latina, I have to recognize my own biases in my own culture in order to be sensitive and to do better. So the challenges with service utilization may require changes in setting. Maybe community-based approach would be a better place and safe place, recruitment strategy, and also incorporation of relevant sociocultural factors in the treatment. So I think that you will have access to the PowerPoint. So in that sense, you will have access to the reference. And I think that we are ready for questions.
Thank you so much, Dr. Maylin Reyes Rodriguez. I will now open up the floor for questions. If you have any questions, please type them into our Q&A box. I'll also like to let you all know that you will be receiving an email containing the evaluation and also a PDF handout of the slides from today. And those will be sent shortly after the webinar. If you have any questions, once again, please place those into the Q&A box. If we run out of time, any unanswered questions will be responded to by Dr. Maylin Rodriguez, and we will send those out to you via email within the next 2 weeks. Okay, our first question is DBT and or other mindfulness approaches used as an intervention or treatment approach to address the intense emotions that a person with binge eating disorder or bulimia nervosa may have? And then it's a double question after that. Has it been appropriate or widely used in Latinx population?
Yeah, regarding that question, yes, DBT has been using for emotional regulation, but we don't have any specific study documenting cultural adaptation with Latinx. So I don't have a specific information about what could be changes or cultural adaptation that could make the DBT more appropriate for the Latinx population.
Okay. We have another question. It says, what ideas do you have about how to improve screening in primary care, given time constraints or training in publicly funded mental health settings?
Yeah, I think that the same way that in primary care setting we have some specific question like prime to assess depression and anxiety, and I think that physicians are doing better to assessing depression and anxiety. I think that we need to identify few questions that can help providers to identify any potential eating disorder. Obviously, they will not do a full evaluation, but I think that it's more about raising the awareness. This is a possibility that this patient is struggling with eating disorder, and make a further refer that patient to an eating disorder expert to do a full evaluation. So I think that we need to identify when I say we is the eating disorder field, those who we are working in this field, we need to provide them with the specific questions that they can incorporate in their regular assessment that they do with all of the patients for depression and anxiety in order to identify potential patients with eating disorder.
Great. Our next question is, what are some biases that you have noticed and how did you handle them?
Biases in terms of
I guess with the Latinx population.
well, I can speak from my experience. As I said before, even when we are Latinx, we share a lot of cultural values. We are very different depending from where we are from. And when I moved from Puerto Rico to North Carolina, one of my goal was to learn from the Latinx here. Um, Primarily, they are from Mexico, and trying to learn their experience listening and being humble about that, because I am Latina, that doesn't mean that I know everything about my culture, because my experience is very different from other Latinx from other country. So I think that is listening, is not assuming that we know everything. When I am working with patients from other race or ethnic background, this is what I trying to do, recognizing that I don't know their culture, that I wanted to learn. Sometimes when they are presenting some symptoms that that I don't know if this is part of their culture. For example, we see patients that they have a different eating pattern. So I usually double check if in some way culture could be a contributing factor for that eating pattern. And that helped me to distinguish between this is part of an eating disorder or this is part of a cultural issue. And usually patients, they are very grateful that sometimes I ask questions related to their culture, and that I am sensitive to recognize that culture play an important role in their life and in their manifestation of a disorder. And I think that is by asking questions, not assuming that we know everything. And as I said before, especially for Latinx from other country, for me was trying to understand why they are risking their life crossing the border. For me, as a Puerto Rican, was something that I didn't understand. And when I moved here and I started listening to their story, I realized now I can see why they are running for their life. And I think that that was my waking call in that sense.
Thank you. Our next question is, do you recommend to assess for eating disorders as part of the psychosocial assessment compared to the general questions already included about eating issues?
Um, I think that I am not familiar with that specific question, or I am not sure what specific question that the participant are referred of. But I think that we need to, and I know that because of the stigma, it's not like an easy process. I think that we need to find the way in which we can navigate through the stigma for Latinx in terms of eating disorder, because I think that sometimes it's not only about asking questions, because sometimes we can ask the question and maybe they don't feel comfortable answering those questions. Um, so I think that sometimes it's not only about asking the question. I think that we need to, in addition to have the assessment in place in primary care setting, I think that we need to raise the awareness of this is something that happened also in Latinx. And in that sense, we can decrease a little bit the stigma of having um, the eating disorder, because I think that most of the stigma is related because they feel that they are presenting a disorder that is not for Latinx, that is more for whites. And that is the piece that I think that we can work on psychoeducation, on raising the awareness. And in that sense, if we have the specific question that can help to identify something that is not going well, if the patient is not having a regular eating pattern, um, or other kind of specific symptoms. For example, the Latina who was asking to different providers, she went to a dentist and he noticed that she was having some issue with her teeth. And that was the moment that she said, I think that I have bulimia, but he say nothing. So I think that she was very clear that, and he saw that something was going on, part of because of the purging behavior, uh, but he didn't refer her for further evaluation. So I think that it's very complicated in the sense that we need to target different areas in order to enhance the refer process and the identification of eating disorder in Latinx.
Thank you. We have room for one more question, and then I will also let the attendees know someone asked how could they follow up with Dr. Reyes Rodriguez for specific questions about her research and work in Latino population. We will provide contact information for Dr. Reyes Rodriguez in the evaluation email that you will receive after the session. Our last question is, I love how you created a conceptualization for your client in this way. Do you have any other ways you help your clients see your insights?
I have to say that I don't do that kind of conceptualization for every patient. I think that with some patients we need it. With other, maybe we don't need to do that specific graphic. Um, I think that because of her complexity, and as I said at the beginning, I did it more for me to try to put together her pieces together. And then I realized, oh, if this is helping me, maybe it could help her to see her story. Um, but beside of doing that specific diagram, I haven't used any other specific skills that I can share to help the patient to see what is going on inside. But I think that sometimes we have as a clinician, the gut feeling that I need to do something to help the patient to understand her situation, or I need to do something for myself to understand the situation of the client. I think that sometimes we need to follow those gut feeling, because as a clinician, sometimes we know that what we need to do.
Thank you so much, Dr. Maylin Reyes Rodriguez. I wanted to let you all know once again, for all the unanswered questions, Dr. Reyes Rodriguez will have these questions answered, and we will send these responses to you via email within the next 2 weeks. As always, NC truly appreciates your time and attendance. Please stay tuned, as we will have these monthly webinars available. You should receive an email shortly after this webinar ends with the evaluation along with the slides from today. If you have any questions, feel free to reach out to us. Thank you so much for your time.
Thanks.